Good morning, everyone. Rob Creed here. Thank you for all joining us on a Friday here in the end of June. We'll give everybody just another couple of minutes to get in the room here, and then we will record this and we will get started. All right, it looks like everybody is here that is coming, or at least that are getting here on time. So again, welcome to our HETA insurance town hall meeting, kind of getting you the information that you guys need around what will happen to the insurance changes beginning in January of 2026. So I'm Rob Creed, I'm the president here. Thank you all again all for being with us. We have our executive director, Britt Wegman, with us. We have our vice president, Regina Gambrell, with us. We have our secretary treasurer, Val Chuchman, as well. And we also have Tracy Schatzberg. We thank Tracy for joining us from Hillsborough County to talk a little bit about, or help us fill in the gaps if with what's happening, how we got here, and kind of where we're going is really what we're going to talk a little bit about today. So with that, let's go to the next slide, and we will have Q&A at the end. So please, as we go through this, the concept is we'll kind of get through the presentation and give the information that we have for you, and then we'll take questions that you might have afterwards. And then exactly what we're going to be doing to kind of help the situation and where we're going forward. So what is going on and why? Well, we shifted for many years. We were with Humana, and then we shifted to Aetna, and we went with Aetna originally, and we'll see the data because it had the best plan, the least amount of disruption for our doctors and cost and prescriptions, specifically around cost. And Tracy and Britt will be able to speak to that a little bit about how when Aetna came in, they were coming in with the idea to kind of take our large district from Humana and cover us, which they did very well for a couple of years, but we're going to show you what they're talking about with increases coming. What else we have, Britt? Next slide. And so we're going to shift to a self-insured model. So we'll also get into the weeds on that a little bit, but ultimately that's where the district will pay out the claims, but we will continue to use Aetna's network of doctors. And the decision to stay with Aetna, again, was to have the least amount of disruption for all of the employees out there with the doctors that you already have, the relationships that you might have with them, the prescriptions and everything else. So everything you have right now will still stay the same in terms of who you see and how you want to go about that. And that was important as well. And then Aetna will continue to manage the claims, and that's what they'll be doing on the back end. So they're kind of like the administrator of the insurance, where the district takes on the risk or paying out the claims. And again, where we began, where we've always been, and what we continue to do is we protect the no premium cost plan for employees. That's what's in the contract. That's what we shared with you when we sent out the email communication. I actually quoted the language in the contract. So, in a nutshell, and I've said this before, the no premium cost plan maintains, and we protected that again, but that drives costs higher in other avenues and other spots, including, your co-pays and your deductibles, and even the family plans. So we will come back and talk about what we could do about it and what we're going to do and help you get information from you. But that's really what it comes down to, is the union, HETA, protecting that no premium cost plan, and one that other surrounding districts don't have. And often our district says, hey, come here for free insurance. Again, nothing's free, but it's the district paying those premiums, not the individual, not every month. So moving on to our next slide. And I'm just gonna pass it right on to Britt, who's going to help us out with the next few things.
Yeah, so we just kind of put together some FAQs just kind of based on, what we know from the committee and just kind of some general things to kind of walk through what Rob kind of introduced. So, of course, the big question is, why are costs increasing? So without saying, in too simple of terms, healthcare costs they're rising, and they've been rising, and they're going to continue to rise. And the district, through the input of the committee each year, has been able to manage those rising costs thanks to carriers like Humana, who we had previously, that were willing to take a little less in profit, which is kind of something that we see across the state, or had seen across the state, where carriers saying, look, we want to do business with school districts, so we'll take a little bit less in profit. And that is not the case anymore. Humana has, pulled out of the state as far as providing coverage like that. And we have Aetna now, and I believe it's United and Blue Cross or Florida Blue or some of the other providers in Florida. So to kind of really show what we looked at in the committee, let me go to the next slide here, that tells the story of what's happened over time is, since 2016-17, you can see, premiums are the money that's paid to pay for our insurance and claims and all those things. And then there are their actual claims that, that's the bill. That's the bill that's due for, what each individual employee needs to have paid for their health care. And you can see over time how those renewal increases have remained on average, pretty steady. I think we reported in our newsletter about a 3.5% on average over time, which is pretty unusual when annually we see increases. Before I came to Hillsborough, you're seeing 7% to 10% increases across the state and the nation to renew plans. So what's happened over time is the money that we're paying out, those premiums, that's that blue line, remain pretty steady as the claims and the market trend have increased. And, keeping our costs low over time has been a priority, and maintaining that no premium plan. But now Aetna is saying, nope, not anymore. We're not going to take a cut on our profit, and not many insurance companies are willing to do that, especially in Florida. As we stated, the legislature continues to pass favorable legislation for insurers, but not for the insured. And that's everything from healthcare to your home to your car. I mean, car insurance is a kind of a good example to talk about. If you want your deductibles lower, you got to pay more. If you want to pay less per month, you got to have higher deductibles. So with the fully insured model, which we'll talk a little bit more about what the difference is between fully insured and self-insured and full insured, we were looking at nearly 60% increase to readjust and reset what we had to pay to cover for claims and what is projected to be claims. Now, projection of claims, I'm not a actuary. I'm not one that analyzes that, but based on trends, that's what they're projecting. And the goal is to not hit that. Moving to self-insured, which was something that the school board has talked a lot about. It was a direction that the district was taking from the board, and explored self-insured, which we were able to bring that closer, I believe, and Tracy can correct me if I'm wrong, 30 to 35% on that. So we still have to adjust. So when we talk about a $27 million savings, it's meaning we don't have to spend an additional $27 million under the fully insured model. So I believe, and this was a very, being newer to this committee, this was a really challenging fact for me to even personally accept. And Tracy can back me up. I think we sent over around 20 questions to really you got to show us this data. How do we compare? And there was no way around, working with Aetna to say, just, give us the extra, 50% for free. Just not the way it works. So the next slide that we have talks a little bit about the comparison to other districts, and these are difficult. Like Rob said, some districts may have a no or low premium plan, some don't. Some have less generous coverage. One thing that I know, Rob, we've talked about when we had to make the switch and Humana left, was doing what we could to keep providers and everything as close as we could. to provide services for a diverse workforce. And so there may be differences there. Some have fewer network providers or different. Some have more or less risk based on claims, you know, depending on the workforce, if it's smaller district, larger district, all those sorts of things. So Tracy kind of helped share with us this kind of district comparison slide. I think when we look at deductibles on the lowest cost plan, that's the green bar, you can see where Hillsborough is kind of lining up with these other like size and some of our surrounding counties. I might ask Tracy to kind of help if maybe you could talk a little bit more about this slide. That might be helpful.
Sure. And what I did is I did this, and my folks on my team checked my math and made sure I was doing it right. But I just went to these districts and we looked to find out what the lowest cost plan is. And you're so right, though. We really, the details, the devil's in the details. So I think an actuary, if they saw this, they would go, wait a minute, but what's their network? What's all this and that? But this really is just looking at when you go to a district and you look at the plan that costs the least amount of money, what are they charging? So it's kind of hard to have a percentage and a dollar amount. So sorry for all you math wizards out there who are thinking this is very ugly. So the orange is the co-insurance. You can see every district has co-insurance. You can see some districts have free plans for employee only and some don't. And so like, let's take Brevard. You can see their lowest plan, their free plan is $69.63. But then you see their deductible is only $2,000. So it's you know, we were talking, as Britt kind of said, there's a discussion about, do you keep it low in the paychecks, less when you low in the paychecks and more when you need it, or do you do more in your paychecks and less when you need it? And I would say Brevard went the route of the lowest cost plan is almost $70 a paycheck, and we did this for 20 pay to make it as similar as possible. But then they have a lower deductible, so that's something we could consider in future years if we wanted to do that. And then the blue line is the cost for the family on that same plan. So you can see little, you know, 404. It's not great, it's not awful. And then each district just kind of has a different way of skinning the cat. Citrus kind of surprised me with their $6,500 one, and they don't have a free plan either, but then they only have 10% co-insurance. So there's just different ways of skinning it. You will see, I kind of like to look at Pasco and Pinellas just because there are, you know, drive across the bridge or drive up the street. You can see with Pasco, their deductible is the same, co-insurance is the same, their family is more. They have made the decision in their district not to contribute towards any part of the family, and put everything towards the employee, which means it's kind of a full pass through. So if you look at Hillsborough, well, sorry, let me go finish with Pinellas. Pinellas, I would say, has a prettier deductible and prettier family costs, but then their cheapest plan is $39 a paycheck. So there's always different ways to skin the cat. And here you can see Hillsborough in the middle. This is, again, just looking at our cheapest plan, which if you're picking this plan next year would be the same cost as it is today, 20% co-insurance, a free employee only plan, $4,000 deductible, and $592 for family. So if I kind of look, and I'll stop talking. I know you're like, God, I just asked her a short question.
Oh, no, this is good. No, I was not rushing you at all.
Okay. But I'm looking at family. So 400, 800, 500, 500, 700, 500. They're just kind of, and then it goes down to 173. I don't want to stop too early. There's just different ways of looking at it. So does that kind of help?
Yeah.
Okay.
No, that's great. I think it's great. You helped kind of talk about how you put all that into perspective. And then again, there are other factors that committee would be looking at as far as their claims data. And so we'll just, thanks for that. And again, we'll have more questions at the end. We'll have folks raise their hand and all that good stuff. So next, kind of, what is the difference between self-insured and fully insured, and what does that really mean? So we kind of put together this little chart about, who pays the claims. Under a fully insured model, that is through Aetna. They pay all the medical claims. Under the self-insured model, the district pays the claims through kind of that pot of money. So, think about the premiums that are paid to Aetna, we would retain those and pay. Now, there are some other insurance requirements that we need under the state to have a self-insured plan, which means that we have to kind of have insurance to the insurance, making sure that we have reserves to back that up so that we don't fall below a certain threshold and have catastrophic loss. Premiums under a fully insured plan are fixed, whether claims are low or high. Under self-insured, the district will pay actual claims as they come in, which then leads us a little bit, later about when there is under or overpayment, that money can be retained in that pot of money to then reduce increases the next year or the following year. And that's something that the committee would be able to look at in a more involved way. The risk versus reward, again, in a fully insured plan or a fully insured model, the insurance company takes all the risks, they keep the surplus, and then they just raise the rates, and we have very little, as a committee, negotiating power on that. Under the self-insured plan, the district takes on that risk. Like I said, it's their pot of money, so they've got to have some backup. So unused funds would possibly back up if claims spike or there's catastrophic claims. The plan control, Aetna kind of runs the game. Here's the plan options, plan design. We have input, but not, again, they hold all the risks. So they get to make, they kind of lead that discussion in that direction. Under the self-insured plan, we would have more flexibility on the plan design because we could really look more closely at our claims data and what's really going on. The transparency, again, general access to claims and spending details. In a self-insured model, we really get more detailed access to real-time claims. So what typically happens in the committee now is we meet annually and we get to see the year. We don't get to see month by month. In a self-insured plan, because we're paying the claims and paying that out and kind of managing it in that way, we're able to see that data a little bit more real time. And I put a note here that is not, we're seeing individual employees' data. HIPAA is still protecting individual info. It's still kind of aggregate in that way. And then HCTA's role under a fully insured and a self-insured model is under that fully insured, again, we're a seat at the committee. Rob and I attend, or, that could be another member, but we're basically one voice out of that committee, which meets annually. And we give input. And again, as Rob said, we can, make statements and put our position out there. And again, defend that no premium option for employees. But under the self-insured model, the committee is ready. We're going to have to meet monthly. We'll have more input and more influence on plan design and really looking at that data because all the risk is on us. So this matters because the self-funding gives, the district and then the committee, right? HCTA, HSEF, HACA, and retirees all have a seat, more access, more input, and opportunity to shape what that future looks like. So, that first year of transition, kind of setting ourselves up for success. But it still doesn't solve the issue of who pays when costs go up. So all of this is still determined by, what does a claim cost? What is a drug or a service or a provider charging? And those are the things that, are dependent on the market. So the next question we got is, again, kind of related to what I mentioned earlier. Will the district see my personal or medical info, like doctors I visit, prescriptions I use, et cetera? Absolutely not. Under both these models, fully insured and self-insured, individual medical information is still protected by federal law. The committee, we don't receive names or diagnoses. We would see, again, aggregate numbers of usage and that sort of thing, but not individual information. And the committee will, again, see that kind of anonymous aggregate data. Another question about who would be approving and completing, again, pre-authorizations. It's not the committee that does that. It wouldn't be Rob or me or Tracy or a school board member. That still runs through that insurance company that does the pre-authorization and claims management. Now where this kind of shifts is that as we get into this and we have more input during the committee, we can direct Aetna on certain things that we want to see. And again, that's all going to have to be balanced with, if we add this service or we add this coverage, how much is that going to cost? And that is also dependent on the market. So again, decisions about your procedures, prescriptions, referrals, not the district, not the union, it's not the committee. So those are just kind of the high level questions that we kind of put together. I know as we get to the end here, like Rob said, we're going to offer that survey that will be coming in pre-planning to kind of look at what direction we want to go. we're working with the district on this cost-saving primary plan. There's a few things that that under the self-insured model allow us to add some other options. One is Lantern, which is Tracy, correct me if I'm wrong, that's where you can have an option to get surgical procedures at free or severely discounted compared to, now, that doesn't mean you have to go with Lantern. You can still use your doctor that you want to use, but if you're looking at, okay, out-of-pocket costs, Lantern could be an option for saving costs. And then the primary care would be, we're meeting, I think in a couple weeks with a group called People One, which is already implemented over in Orange County, which allows for basically no copay. You go see a primary care doctor at a facility. And again, that helps drive costs down. So what our goal over shifting to self-insurance, the goal is to bring claim costs down. That's what it comes down to. How much do we got to pay in a bill? So before I get to kind of like questions and raising hands, I don't know if Tracy or Rob had anything that maybe I missed or misspoke on.
No, really good job there. And I just want to say first, like, you know, all of our members will get a survey the first day of pre-planning. That's going to cover a bunch of different things. To begin, like, you know, how do you want us to negotiate hurricane makeup days if by chance we need them in 25 or 26? But then in that survey, we're also going to ask other questions around health insurance. Like, do our members want us to negotiate something other than a no premium plan, no cost plan for members, so that way we could drive down the cost in other places? So we will have a comprehensive survey for you to fill out. And again, we just follow that which the members want. And we could figure out different ways to do this. When we go to that meeting, our primary concern is making sure that we're protecting the contractual no premium plan for no cost to the premium plan for members and employees. So with that, that's where the cost went up with copays and deductibles. And then we are working with People One, which would be a no copay primary care service. And that's something that we're still in the early stages on, but we hope to have that kind of rolling sometime in 2026. And Tracy, can you just speak a little bit, further about what Lantern is and how that's a secondary level of support for surgeries and things like that?
Absolutely. We're excited to have Lantern coming on board. It will offer a free surgery. When I said it recently, it just sounds funny to say free surgery. You get a surgery, you get a surgery. But the idea is they contract with highly vetted surgeons and surgery locations, and they offer a bundled surgery price and at a much reduced rate. And so for the district, we would pay less because it's all about the claims. We would pay less when a person does their surgery there. So let's say they need to have a hernia repaired. If they were to go through Lantern and use Lantern surgery, instead of the surgery costing the district $14,000, it could cost about $7,000. And so then you might think, well, but why would I care? I want to, I'll go wherever. Well, we want to get you to go there because we want to save the $7,000. And by doing that, we will waive your deductible, waive your copay. So to try to encourage you to go. But if you love your hernia doctor, you stay with your hernia doctor. So there's no real money that we're putting out for the program. It's really more like if people use it, then we'll have the savings.
Right. Thanks.
Thank you, Tracy. And on top of that, HCTA is going to have a new benefit for members only. That's going to be HCTA Member Assist. It's going to be a concierge service that's going to help you with your medical insurance, all of the different benefits that we have from FEA, NEA, AFT, and HCTA. But why I bring that up here is that let's say you're having an issue with the medical insurance, you'll be able to use our HCTA Member Assist program to find the most cost-efficient way to, to get that surgery or to find the doctors that are going to meet you and your family's needs. So that's just another level of support that we're bringing coming in 25 and 26. And I hope to be able to present that HCTA Member Assist program when we have our Get Back to School Zoom right before pre-planning as well. But and thank you, Britt, and thank you, Tracy and Val and Regina. So it's that time where we will take questions from anybody that has them out there, because we just want to try to be clear about what we're doing and where we're going. And again, all of these changes take place in January of 2026.
Right. All right. So I'm going to start with Mr. Robert Barnes. You should be allowed to unmute yourself.
Hello, can you hear me?
Yes.
Yes, sir.
All right. Two quick questions. A number of years ago, my wife had a serious medical episode where she was in the hospital for months and months. And I remember something wasn't covered. I don't remember exactly what, but I remember calling the district or calling Humana, and they said, well, is your district self-pay or insurer paid? Because if it was self-paid, you could appeal to the district and possibly get that uncovered service covered or waived or excused or what have you. Is that kind of what you guys are talking about with the monthly meetings? Like you would kind of bring up appeals that had come to the district or to CTA or whatnot? Is that what you're speaking to?
Yeah. I mean, I think that would be included, and Tracy can help too. I don't know if it would be that direct, but I do know that we would have the ability to say over time, hey, this is something that we're seeing that we now want to add into our plan. Is that
Okay.
more correct, Tracy?
Yeah, it would be more like that. Our committee would never be in the position of voting yes or no on someone's appeal. That will be handled by Aetna, but Britt's exactly right. If we start to see that we are having issues over here or things over there, we could make a decision to say we want to start to include something, or we need to change it and not have that be included. So that's the function of the committee, but it would never be, can Robert get what he needs, or Robert's wife get what she needs? That's
I
not
see.
the goal.
Good
Okay.
question.
And then I had one more, with going to self-insured, does that mean the district will have to hire more insurance people and more skilled insurance people? And what are those salaries going to cost? Is that something that, could potentially cost more than it's worth?
Gosh, Robert's
Great
question.
question.
Good questions. Yes. So as Rob indicated, we're still working with Aetna, and Aetna will still be adjudicating the claims. We'll still have Aetna advocates on site. And so if you ever have a problem or a question about a bill, call us and we'll see and make sure it's correct. So they will continue to do that. We have a whole cadre of individuals on Aetna and with our health and benefit consultant that will support us. We would like to bring on just one additional person who is really going to help kind of stay on top of the claims and trends. So we're going to meet monthly, but this person will be looking at the information daily kind of stuff. But we are not needing to bring on a bunch of new people. We are paying money to Aetna for their network and their management of claims.
Okay, so the district would hire one additional person just to be an extra helper or something like that?
Yeah, just one person is what we're looking at. Yep.
Okay. All right. Okay. Well, thank you so much. Appreciate your answers.
Robert?
Thank you, sir.
All right. Go ahead, Katie.
Hi, can you hear me?
Yes.
Okay. So I just have a quick question, and I've talked about this with Rob and Tracy a lot over the past year around GLP-1s, and just I've learned more as the year has gone by about denial claims that I've had through Aetna. So when we're collecting the data and we're pulling the data, are we pulling the data that shows what is being denied to employees? Like, okay, Katie put in, and Katie put in a claim for a GLP-1. She's denied because we're only covering people with diabetes. Are we looking at how many people are putting in, I'm just using that as an example, claims for medicine like that, and then seeing how many employees put in a claim for that, how many employees were denied, and then looking back at the table, hey, are we going to change? Okay, now if we have, let's just use an example, 60% of our employees being denied some medication that they're looking for coverage on, are we going to go back to the table and say, okay, is this something that we should now be covering as a district?
Right. So I would say under our current model, as far as our position on the committee, we don't get that particular information because it is based on like, this is what these drugs cost. But under the self-insured model, I think we would, but Tracy maybe can help me with that too, as far as like when we're looking at, again, I think all of that would be, because then again, the whole goal of going self-funded is we have a little more of a, we have more control over that design. So denial data, would that be part of what we look at, Tracy?
Yes, we certainly can, and yeah, you're right. Right now we get kind of aggregated data, but we'll be able to see what's being denied, what's being accepted. And then the tough conversations will begin, because let's take the GLP-1. It's like a life-changing, wonderful medication that's been created. In 24, Aetna, because we pay Aetna, $9.1 million on that particular type of medication that's for, at this point, as you indicated, required for diabetes, only allowed with diabetes. So what the committee would look at then is, if we were to extend that, what, instead of 9 million, how would that increase in cost? And then we would figure out if we can do it. So it's like, it's going to be exciting, but also it's we'll have to make some tough decisions with that kind of stuff.
Okay, so my follow-up question to that then still goes back to the whole denials, because since I'm not just even referring to the GLP-1. So currently, do you guys get data on Aetna's denials? Just because I've been a little shocked this year on even like some blood work that in previous years had been covered. Like I just had to pay out $300 to Quest. Like with Aetna, there's been a lot of things that with Humana were covered that I guess kind of as a person on the insurance, it isn't that detail broken down when I get it as an employee to know, oh, hey, when I went to the doctor this month and they felt it was necessary for me to have this blood work, well, Aetna didn't feel like it was necessary, so it got denied. Are you guys so you're not getting that data right now? Because I know like we talked about how like, oh, people aren't going over that deductible of $1,250. Well, if you look at some people, you're not even seeing my out of pocket because Aetna's not even paying them. So they're not even hitting my deductible. Does that make sense?
It does. And so no, we don't get a weekly report or a monthly report. Here's the denials. But it's a great point. So we will start to get that for sure. I would say, Katie, Aetna was supposed to match what Humana provided. So would you reach out to me offline? Because I also want to make sure that it was handled appropriately. I know sometimes it's a billing issue. I know personally I had trouble at like Florida Orthopedic trying to get them to understand there's no copay for PT when they insisted that there was. And it seemed like it was an Aetna issue, but it was really the doctor's office. So can we talk offline? I want to make sure what's happening there is accurate, because really when Aetna came in, part of why we picked them, as Rob indicated, is they said we will match what Humana matched. So follow up with me if you don't mind.
Yeah, I don't mind at all, because I was really surprised with just like Quest blood work, not expecting to be paying out money. Like I understand the whole GLP-1 and we've gone around the circle of that conversation, but I just think that it's really important that when we're doing the survey going out to staff, I think it's great that we're looking at like, do people really want a zero cost situation? Or would they rather pay something monthly, and maybe that does provide some other drugs, that aren't currently available? And then really looking at like, hey, I know we said the $1,250 was what people hit, but I would really love to see on that survey question if people are willing to share what they paid out of pocket that did not hit a deductible. I know, Rob, some people might not be willing, but maybe you could just put it on there as, hey, if you are willing to share these additional pieces of information, obviously HIPAA says you don't have to, but I think you would be surprised what people are willing to share if it's going to improve overall healthcare.
Yeah, Katie, absolutely. I could add that question. I just jotted it down. I'm also willing to take a question and put one out there that covers kind of what the challenge of the GLP-1s. And what I found out, I believe the only district around us that's still covering it for things other than diabetes, I believe, is Pinellas, and they're trying to figure out a way to not do that because of the cost. Again, I think if we're just transparent about what the cost could be, I mean, I don't mind asking that question of the membership as well, and how to go about negotiating that for you guys around that.
That would be awesome, because another thing that I've seen people do with their insurance that I've brought up before is you make it a specialty drug, and then I just pay what is Aetna's cost. So for example, I'm just going to throw it out there, a number. It's not right. Let's just say it's 250. So let's
Right.
just say that one costs 250. A lot of people will negotiate, okay, it's a specialty drug now. Katie, since she doesn't qualify in here, but her doctor's still prescribing it, if she's willing to pay 250, she can still get the drug versus paying full price value of over $1,000, if that makes sense. And I would think that would be another question that if you posed out to people, you might be very surprised how many people would be on board at looking what would be the cost for that, because I've spent a lot of time talking with a lot of people, and I think a lot of people are willing to pay a little bit if in the end they're not paying. If you figure out the cost differential in the end, you're actually saving money if you really truly do want to be able to have these medications and these services, and like how she's talking about the different surgeries and stuff, which I think is great that you're looking at other avenues, because people are willing to try different things and do different stuff. I just think as a district, we have to be more robust in looking at different things. And I think Jessica Vaughn made a really good point at the school board meeting. Like, we need to be reaching out to lots of insurance companies. And I know they don't all want to work with us, but we have to
Right.
make sure we're coming to the table with as many options as possible, so that we can give people the best opportunity possible. Because you have to look at the end of the day, when you go from 1,250 to 4,000, while, hey, you might have had a good year one year, you're rolling the dice with a huge difference in that deductible.
And Katie, you bring up a lot of really good points, specifically around the claims that have been denied. So when we go to self-insurance, the good part is that we have more control over it. The bad part is we have more control over it. So we could get into it a little bit more. We will have a member committee with that. You would be perfectly suited to sit on that committee to kind of help drive what the members want based upon the data that we have. But thank you.
Sign me up. I'm ready. All
I
right.
know.
Thank you.
All right,
Thank you.
Katie. All right, Jennifer Burnett.
Hi, I just kind of wanted to piggyback off of what Katie was saying. I want to thank CTA first of all, and Tracy for being a part of this. I think it's good bridging that gap like we kind of talked about last year. I just kind of wanted to say this for the greater good of everybody, because I know that there's been a lot of talk on the CTA page within the past year, again, about the GLP-1s. We went through a lot in learning about those claims and who is denying them, right? So Aetna isn't necessarily denying them. The district is saying, we're only going to cover it for diabetes. So I just wanted everybody to know, no matter how much you try to, I guess, appeal, because I've gone through a year of it. I don't want anybody to have to go through that, that mental game. Just putting it out there that unfortunately, if they deny it, like it's denied.
Yeah, sure. On certain things where, that was a decision that had to be made at the time of, is the district going to put out these additional, $9-10 million, or is that not going to be included in the plan? Now, I think what Tracy's also talking about and what Katie brought up, if there are things that had been included before that we were told should
Correct.
be, definitely reach out and try to work with the district on, really getting to the bottom of, is this something that Aetna should be, that they're incorrectly denying, versus, actually, this is something that we as a district had to make the tough decision to not include under coverage because of exorbitant costs. Because I mean, prescription drugs in this country is not run.
For sure.
That whole industry is not run to help people get better. It's run
Correct.
as a hedge fund. And that's what's so frustrating, and kind of our message out there that, like, the healthcare industry, insurance companies, pharmaceuticals, they don't care about our school districts and people. And so I really appreciate you pointing that out, that there is a difference between something that we as a district are deciding we can't cover that just because of costs and where we're going to come up with that money, versus.
And it's not really to speak out like saying the
Yeah.
district's bad or whatever, just through
Right.
the year of going back and forth, I wish that I just would have, taken that denial and then called Tracy, and Tracy could have told me, no, it's just covered for diabetes or it's just
Right.
covered for this. And then that would have been stopped because it was like there was a break between Aetna and the district, and the right hand didn't know what the left hand was doing. So there was a lot of confusion and a lot of time wasted. So I just wanted to put that out for everybody so that they didn't have, those same problems and struggles.
Yeah, appreciate that. Yeah. And I think one of the things that I'm looking forward to with the committee is the education piece. That meeting once a year, you kind of get like, here's the snapshot of the whole year. But the committee having an opportunity to really pass along education to employees about this is what's going on. Here's where we are statistically in our claims and that sort of thing. So we're looking forward to that. So, all right, I think Denise is next on the list. Let me give you permission to unmute yourself, Denise.
Good morning, or good afternoon, rather. Or no, still morning.
Still
I just wanted to comment. I'm not even sure this is the right place to do it, but I had signed on because I wasn't sure what the conversation would be about. But my lab costs have gone up tremendously. My husband had a prostate biopsy that most of it was denied, even though he has cancer. So it was a positive lab result. And we had over $1,200 for the first set of lab costs that were not covered. So of course they were greater than that, but to the realization that the two Humana and Aetna's insurance policies were not equal, and that my lab costs would go up significantly was very disappointing.
So Denise, I would like to confirm, I will say when you say $1,200, it makes it sound like it's a deductible issue, but can you reach out to me as well?
Yeah, well,
Let's
my
just confirm
deductible, it was significantly less under Humana.
Well, we have the same $1,250 on Humana that we do today. So let's just check and make sure that there's not something that's gone wrong on that one.
Okay, well, sure, I can reach out. Thank you.
Okay, thank you.
Yeah.
Thanks, Denise. Tracy, is that normally where we find those? Because I don't recall ever talking about lab, the lab fees per se. So go ahead.
So preventive is still covered, because the Affordable Care Act. So most of our stuff is free, but if you're going to run different panels, I'm getting old hormone panels, whatever it is you're going to have, those things will start to go towards your deductible. So it could very well be. And I don't know if I would like to really quickly mention, and it wouldn't necessarily help with blood panel stuff, but I want to encourage folks to look at some of the voluntary plans we have, like the GAP plan. And a lot of people have the GAP plan and forget that they have the GAP plan. So the GAP plan, if you purchase it, is pretty cheap. And if you purchase it younger, that you lock in a cheaper rate, and it will pay back 5 co-pays annually. So it usually covers itself. Next year, with things going up, it's going to cover the higher copay. It will cover ER visits. I had surgery a few years ago, was in the hospital for a few nights. I got back $2,000. And it's really cheap. So I would encourage you to look at that. Also, some things to consider, accident insurance, critical illness insurance, the things that we don't necessarily want to have, but that it helps when things like a cancer diagnosis comes up. My husband and I were in a golf cart accident a year ago, and turns out a golf cart's not a car. So our health insurance, and he needed surgery. So luckily he had accident insurance. So that was able to kind of curb some of the spend. So I'm sorry, I kind of took that off on a different path, but I wanted to make sure that in this annual enrollment period, people look at that stuff.
No, I appreciate it because, what Denise brings up, I've actually never heard of that issue. So thank you for that.
Like how I told everybody I'm old.
No, I think
You're not,
There you go, Rob. Thank you for you bit.
you're not.
I appreciate you.
so,
Philip.
yeah. So before you go to the next person, I think this is just kind of a good time to kind of reiterate what the goal and thing with under self-insure with the committee to be able to look at these things and put out education pieces. Because I was just having a conversation earlier with a colleague about, sometimes you may find a new provider or you go somewhere like a new dentist, and the person there is looking at a generic page. They're not necessarily looking at your plan. Or coding may be incorrect. So sometimes it seems like, well, that person that's sitting there behind the desk with the computer, they know and they're telling me, but we really do. I mean, it is worth advocating and educating and saying, hey, I'm not sure about that. Let me call Aetna right now. I remember doing that with my dentist because I'm under this same plan with Aetna and saying, that doesn't sound right. I should get this or not that. And then, of course, reaching out to Tracy's office, especially on things that were the same. Why did they go up? And really researching that. So then you are educated, and that goes to kind of what Jennifer was saying, being educated and not just letting it happen and then sitting back and saying like, oh, the insurance company, the provider did this to me. So that's just a note on that. So I'm going to go to Carissa. You can unmute yourself and ask your question or what you got.
Hi, a couple of different things. One, with the mention of transparency, is there a way to put it somewhere? Maybe there is, and I don't know it. So maybe I'm going to start with is there a spot where we can see what things aren't going to be covered because the district has decided not to cover it? Like the GLP-1s, that's a really big thing. There shouldn't have been 100 people going around asking, not knowing whether GLP-1s were covered or not. So can there be a thing of, hey, we are not going to cover this common thing that's occurring? Again, this might be something that happens now monthly, that, hey, and it should come from the district wide. We are not going to cover these unless it is this.
I think we can determine how we want to do that. If we make changes next year midway, I think, yeah, we would work together. I'm sorry, I just kind of jumped in there, Britt, and then figure out if we're going to make changes, how we'll communicate that to people. We do have certificates right now that you can, that will list what is and what is not eligible. So those exist, and you can find them in our microsite and also at our the location where you log in to get benefits. All of our certificates are in there that will indicate what's covered and not covered.
Yeah, so that I think goes back again to like that education piece of, let's just remind everyone, because it might be one of those things that you don't think about it until you think about it, right? That, oh, there is a place to go find this. And if something, and then more people looking at it and driving there may say, hey, I don't see this on either list. So maybe it's something that we as a committee then need to bring. So
well, point. is why it's going to sound like I'm just being argumentative, but why are there 5 million different places to go and look for all of that information? I mean, go find it on Teams, go find it on SharePoint, go find it on Infor, go find it on now this another website that I use once a year to make my elections, and then I never go to again, because whenever I sign in, I have no idea what my login is. I hope it's on the single sign-on, but I don't think it is. So, like there's 5 million. So one thing that the district really needs to work on is, here is a spot. This is where you find all of your info. I shouldn't have to go and find 10 different spots to go and look for the information that I need from my employer.
Heard. I think that's been something, even when I was here teaching, was, you go to we had advocated to find that one click on the website to go, and then it's a panel of all the different logins. And I will say that's not unique to Hillsborough. In my experience across the state, that's a desire and need across everywhere to be able to go to one-stop shop for everything.
And then second, sorry, I have another question.
Let me, with regard to our certificate, it really, where you log in to do your benefits is the location where it needs to be, because we can't have something that people have to just be an employee with. So we have people on COBRA, we have retirees, we have people on leave who wouldn't have access to our staff hub or our team stuff. So that's why our one location is where you log in to get your benefits.
Is that part of single sign-on now?
It is your own sign on and create that you create your own password. It's not related to your Lawson number at all. It's what you set up. So it
Okay.
is usually one time, but no, you can't go into Teams and get to Alight. No. But that is our one location because we need one place that everybody can access.
Okay.
But we probably need to do a better job of communicating how to get there. So I appreciate that.
And then, so my second question is about the no premium. I'm looking into this. I've talked to Rob a little bit about it. One, I think most people, when you are going to talk to people about taking that no premium offer off, they're going to say, what is it going to get me? And right now, the information that I think, or that I've processed through, is we don't know. And for a lot of people, that is not going to be good enough of, well, what's going to happen? So if I'm just going to throw a number out, but if it's $50 a paycheck for myself to be insured, what is that going to do for me? I understand that it could help the family and the other costs go down.
Right.
But if I'm still have the same $4,000 deductible, if I still have the same $80 specialist, like that's, why am I going to raise mine, raise my costs personally, 50 times $20,000, I'm going to raise my cost $1,000 and see no benefit from it.
Well, and around that, Carissa, and we spoke on that. A survey that we do in August, at the very beginning, won't have those details. What it would be a precursory look to see if they want us to look to kind of explore that. If the membership overwhelmingly wants us to look at those options, then we would dive into, well, this is different ideas of what it could look like. Would you want to support some of the, it would have to be a follow-up from that. But yes, that way, before we agree to anything, what it would look like for families or for your deductibles or copays.
Could you do something in that survey to say how much would you be willing? Like because I think that would make a
Sure.
difference in there as well. Is I'm willing to go up to $50. I'm willing to go up to $100. I'm willing up to whatever it is.
That's a good question. Yeah.
And they're just so that, because there might be a limit. There might be like, yeah, sure, I'd do that. And they're thinking, I think I mentioned $15 and you said, no, it'd be way more than that. Well, if it's more than that and somebody else was like, yes, that's great. That's.
Yeah. No, you're right. And Tracy showed us that slide earlier that gave some of the locals and what those amounts were.
Mm-hmm.
So I think that maybe we would look at, start with that kind of as a base, at least for conversation. But that's a really good idea for a question as well.
Yeah, and I
Thank
think
you.
some of that might even come down to, look, we're looking at an increase just because of, rising inflation on, services and everything's being charged more. That the exchanges, would you rather see an increase to your deductible or pay more now? It may just be that too. Or would you rather absorb the cost in your paycheck versus seeing it play out otherwise? So.
Yep.
Right. And that's kind of what I was talking about, Britt, is like, I think that people, there's just been a lot of kind of talk of, from what I've heard, again, if I'm misunderstanding, please correct me. But what I've heard is that if what is it, 80% of the employees use this no premium option. If they all paid a little bit, then the families would pay less. So, I think that sounds nice, but I'm willing to pay a little bit for the families to help them out. But if it's going to be quite a bit more, significantly more, $1,000 more a year for me just to be insured, and then only the families where my family is not part of that, is, I hate to be that person. I know that's better for everybody, but if there's no direct benefit for me, then I need to know that too.
Right.
That does make the difference.
Absolutely.
I think a lot of members would look at it through the same lens. And honestly, that's what makes what we're asking difficult. Tracy, what is the percentage of employees that are on the, you know, the no cost premium plan?
It's about 75%, I think the last time.
Okay.
So
Very
it's a good amount. Yeah, and I think that that's what's so difficult when we are coming together to try to do insurance for 24,000 people. You know,
Mhm.
we're trying to do for the masses and trying to find that balance. So I love that y'all are going to gather some data because there's different ways to skin the cat as we've talked about.
Yeah, it just all comes down to, here's the cost. How do we want to pay for it, right? If the providers, when a claim is a claim, you know, a drug is a drug, a service is a service, it's going to cost X. It's just, you're right. How we pay it, who pays for it, when do we pay for it? And then the more we add to options and what people have access to, again, that's another, you know, line item on the bill at the end of the month. So those are all the things we'll have to look at. So good discussion. All right.
Thank you so much.
Was that it for you, Carissa?
Yes, thank
All
you.
right, thank you. All right, we'll go to Agnes. You can, you may unmute yourself now. We can't hear you. I don't know if, I see you're unmuted, but not sure if we can hear you. Still can't hear you, Agnes. I'm gonna, if you want, you can email us. I don't know if there's something going on with your microphone maybe, but feel free to email Rob or Tracy and I.
Can you hear me?
Oh, there you go.
Now
Now
we
we
can.
can hear you.
Okay. Sorry. Good morning.
Good morning.
Good morning.
I just have a question about the self-insurance you're talking about.
Mhm.
Do you have like a brochure or a website that I can read more about? I need to know like how it works, how much it will cost, like going to the doctor, specialist to compare with what I have with Aetna. And also wanted to know, will my doctors change? Will I be able to see some of the same doctors that I'm seeing now? Or I have to see some of the different doctors that are on that plan and how, how that really works.
Right. Good question. So I think let's kind of like backwards or kind of come to it. So when we talk about self-insured versus
Yes.
fully insured, I
Mhm.
think that just means the way the district is administering or paying for our insurance providing. So when it comes down to what you would pay right now, the plan is, or the, you know, if the board approves it, would be to continue to keep Aetna. And then once that is the district or the board makes that decision, then Tracy and her shop will go to work putting out those documents. So the goal and the plan, if this passes, would be your network, all of that is there. There would be adjustments to deductibles and copays, which then would come. So I think maybe Tracy can talk more to kind of timeline on that. But
Okay.
just to kind of remove the confusion about self-insured, fully insured, that's the district decision on how they want to kind of like fund this whole thing. But as far as what the end game, you're asking like, what's it going to be for me? What does my plan look like? What's it going to cost me? That will
Correct.
come a little bit later. So Tracy, you want to
Okay.
say that?
And actually,
All
I'd say if you were to look at the last board item or the board item, because we're going to be doing it coming up, there's a page in there that talks about the difference in copays so that you can see that. And Agnes, I think you asked a great question. I just want to make sure everybody remembers that self-funding is just behind the scenes. So really it should have no impact on anything. So like, let's say next year you go to the doctor and the door is locked and they say, we're not taking you. It won't have anything to do with self-funding. It might have something else to do with something else, but it won't have anything to do with self-funding. If you have a claim that was paid with Humana and now it's not paid with that, it won't be because of the fully or the self. So that's just going to be a behind the scenes thing.
Okay.
Talking just
That's a good question because it sounds like we're going self-insured and then it makes employees think like myself. So, and then pair that with changes, you can see how that communication piece and the goal of the committee to really shift into that. Hey, this is what we did. This is our report and helping educate employees. So great question. Thank you, Agnes.
Okay. And then one more question. The deductible, which is $1,250 right now, and I see that next year is 4,000. Is that like something they're talking about, or is that going to happen? Because that's a big jump.
Yeah, so it's pending. And again, just to kind of like give a picture of how this came to be, you saw our slide about, I'll even see if I can go back to it.
Yes.
This
I
one
do.
about having to kind of readjust.
Yes. ma'am.
When it came time to say, how are we going to pay this bill? If we're going to maintain that no premium plan that currently has the $1,250 deductible, that was the rub. Aetna is saying, you got to pay us more because this is how much everything is costing us. These are the bills we're having to pay. So what Aetna put forth, what Aon did in their research, what the committee did in giving input was saying, you got to give us the best option with the lowest deductible, still having the no cost. How do we maintain, our network, all the services because we just had this big change from Humana to Aetna. And this is what now, all of that work together is now put before the board to decide. So as it stands right now, we're still under our current plan. Based on what the board decides, it could be that. If they don't, it could be more expensive. If they say we don't want to go to self-insured, we want to stay fully insured, then we could be looking back to the drawing board on what those plans look like. So as it stands right now, it's not approved, but it will be brought back to the board based on all the information they requested. And I see Tracy's ready to jump in.
Yes, I did want to point out, that this is not, while there's a higher deductible, this is not a true high deductible health plan. True HDHP, you pay out of pocket until you hit the deductible. We're still going to have co-pays, so that won't happen. And so now that I'm thinking back through on our the last individual who had that blood work, that it's costing $1,200 under today's plan, we're going to have different co-pays put in next year. For example, there's going to be next year a $200 copay on blood work. Not that you'll have to pay $200 if it costs less, but that it wouldn't cost more than $200. So there's going to be lots of little copays in there, so that you really should hardly meet that $4,000 deductible. In my mind, if you're meeting that, it's because you're likely having surgery. And if you're having surgery, then we would want you to consider possibly Lantern. But this is where you want to pick the right plan that works for you. I think for the first time, people might start now looking, because we usually just go with the cheapest. What we really need to do is look at how much money you usually spend. And if you usually spend less than $1,000, then you're probably better off going with the free plan. If you go a lot, then maybe you want to buy up to a different plan. But take a look at what you spend. And we know that the majority of our members didn't meet the deductible last year. So chances are they would be fine on the lower cost plan, and especially with those additional copays built in.
Okay, thank you.
Any questions? All right, well, that is pretty much it. That's all I have in the queue. I don't see any more hands raised. So
yeah, I want to thank everyone for being here. Again, we're just trying to explain exactly what's happening, why it's happening, and what we're doing as an organization to do our very best to protect all of you collectively. And even as we made the shift from fully insured to self-insured, the pervasive thought was to make it as less obtrusive to employees as best we could. So by keeping Aetna as our manager of it, but yet we have a little bit more control over it, we're kind of wading into the pool a little bit. But as we talked about in this meeting, we will have more hands in the dough, so to speak, in what this insurance will look like going forward. So we will be having more regular meetings with the district. We will be having more regular meetings with our members around it, so that way you all have a say in what we could do to help protect and have strong health insurance here in the district. But like everything, costs go up, and it's a matter of making very difficult decisions. Keeping that free plan, there was no other way other than raising those copays and those deductibles right now, but we're always willing to open up and look at other options. So again, thank you all for being here today. I really want to thank Tracy from the district coming in here today on her normal, Friday that she already did her 40 hours this week. So thank you for adding, spending more time with us. And I'd like to thank Val and Regina and Britt as well for all the work on this. We'll come back to you guys again with it. Just again, thank you for being here. Stay safe out there, and thank you for being a member of HCTA.
All right, thank you all. Have a good weekend.